Thank you very much, everybody. This is obviously very exciting and slightly strange to be delivering webinars from our respective rooms, but I understand there's quite a lot of people joining, which is absolutely brilliant. So we are running under the auspices of the MS Academy a webinar this afternoon on radiologically isolated syndrome. So in terms of the radiologically isolated syndrome webinar, I'm Camilla Blain. I'm an MS doctor at St George's Hospital, and I will be talking about the clinical implications of RIS. Then we have Dr. Audrey Sinclair, who will be going through in more detail the radiology and pitfalls in making, obviously, what is a radiological diagnosis. And then Amy Harbour is an MS clinical nurse specialist who will talk about the very important point about the implication of receiving this diagnosis for the person in question, and also thoughts about how MS nurses can sort of input into this. So as I said, I'm going to talk about the clinical implications of RIS. This is my declaration. So just a brief reminder of the case, which I'm sure you have all seen, as you're sort of leading up to this webinar. So it's basically that we have a young woman who in this scenario has actually got sort of medical and neurological knowledge, but a young woman who has a long history of migraine. And another colleague has seen the lady and has ordered an MRI scan to, as we know, this is never a good idea to exclude any intracranial pathology. And obviously, as can happen, the MRI has come back abnormal. And in this case, the changes in the MRI look very much like demyelination, with two of the areas seen enhancing with gadolinium. Now, of course, what we don't have here actually is any report of whether there's anything infratemporally, and we also don't have an MRI of the spinal cord, both of which are important, as I'll come to later. And then importantly, for saying that this is isolated MRI finding without a clinical phenotype attached to it, as that we're aware of, is that following hopefully detailed clinical history taking in a neurological clinic, there is no history of any previous neurological symptoms. So this is what we would understand to be a radiologically isolated syndrome, changes on MRI alone. So I think this raises obviously some questions that I hope to answer for you today. So thinking about what is RIS in terms of actually how has it been defined and to make a diagnosis of RIS, touching briefly on how common is RIS, and then very importantly for this person and for any of our patients who are presenting to our clinic with this scenario is what is the likelihood of actually developing a clinical event? What is the likelihood of developing clinically isolated syndrome or multiple sclerosis? And what factors might predict this? And then I'll just briefly say, from a sort of clinical perspective, how I feel that this patient might be managed, including that question of should she start disease-modifying treatment. So I'm just going to run through sort of three, I think, of the most important papers which have discussed and defined radiologically isolated syndrome. So the first one, I think, where RIS was really sort of properly defined is by Darin Okuda and colleagues, published in 2009. And they defined it as the presence of incidentally identified CNS white matter anomalies meeting set criteria. And as it was 2009, these set criteria are the Barkov MRI criteria. And very importantly, and this is something that Audrey will go on to later, we must be really clear that they are not accounted for by other pathology. And indeed, this is something I forgot to mention specifically in when I'm talking about the management, sorry, but I'll mention it now, is that we must think about that in clinic and obviously always send off an MS mimic screen, although it looks very typical for demyelination, but just make sure there's no hint that could this be the mimic of sarcoidosis, and make sure an ANA is negative. I also always do HIV test as well. And then importantly for it to be RIS, that there's no historical accounts of remitting clinical symptoms. And this is also starting this thought of like, what do we mean by clinical symptoms? And all the definitions talk about the classic, key, and well-defined clinical symptoms of, say, relapse in MS or progression in MS, but not more subtle symptoms. And then RIS was also mentioned in the revised 2017 McDonald criteria, and they defined it as MRI findings strongly suggestive of MS in a patient with no neurological manifestations, RIS, or other clear-cut explanation, make sure there's not an actual different pathology mimicking demyelination. And then sort of much more specifically and at greater length is the latest criteria, which has been put out by the Academic European MRI Group, MAGNIMS. So this was put out in 2018, and this is quite a long definition, but essentially, similarly, that after detailed clinical assessment, findings are unremarkable for omitting clinical symptoms, and also now that the diagnosis of RIS on MRI conforms to the usual MRI diagnostic criteria from the revised 2017 McDonald criteria rather than Barkov. So the point is that, I mean, unsurprisingly, because we don't MRI the entire population, it is just people who have presented with other things. RIS is uncommon compared to the presentations that we will see in our clinics with actual clinical syndromes of multiple sclerosis. These are the two sort of principal studies, I would say, looking at large numbers of scans that have been done, MRI brains that have been done for other reasons. So in the very large systematic meta-analysis, the prevalence of demyelination in MRI brains done for other reasons was 0.06%, so very low. And then also they were very much reflected in the results from a study from one Swedish hospital who looked at all of the MRI brain scans done for different indications for a whole year and found the prevalence of RIS to be 0.05%. This rose in the younger population to 0.15% of scans done for other reasons. And just to say that, so one could sort of say that, you know, the prevalence in their region of RAS was 50 and 100,000 versus the much higher prevalence of MS, 189 per 100,000. We also know that the rate of RAS is definitely higher in family members of those with MS. Okay, so just a quick thought about the idea of what is RIS. And of course, what we're worried about is that RIS, you know, it looks like the pathology of MS. Why is this not prodromal, preclinical, subclinical MS? And certainly some people that we see have subtle features that we can see in people with multiple sclerosis, but do not have the overt or defined clinical symptoms of CIS or MS. So I just wanted to raise awareness of that. So in some of the series, subtle signs on examination may have been reported. And then this idea of a kind of prodromal, preclinical MS, you know, what is the reason for the scan? There have been studies that have described that people who go on to develop MS have this sort of increased healthcare utility in the couple of years preceding this, increased presentation with psychiatric issues. So, you know, are the actual presentations where we see demyelination a kind of, you know, subclinical MS? And there is certainly cognitive impairment found in people with RIS, with about a third of people in studies found to have some degree of cognitive impairment. Okay, so what is the likelihood of developing CIS MS? What is the likelihood of having a clinical event? So there was a retrospective multi-center a study of around 450 people with RIS published in 2014, which demonstrated there was a 34% chance of having a clinical event, which would move the diagnosis from RIS over 5 years. Of these, 9.6% were to PPMS, and of those, all had spinal cord involvement. I think we'll see a theme that the involvement of the spinal cord is an important predictor. Independent predictors of developing a clinical event were young age, male spinal cord lesion. Oops. Anyway, let's stop there. We've missed something on the previous screen. Oh, there we go. So this has been extended now using a proportion of the same cohort to 10 years. And in 10 years, there's a 50% essential cumulative probability of clinical event. That's so interesting because here we have people who have MRI scans that are typical for multiple sclerosis, but 50% of them by 10 years have not developed an overt clinical phenotype. I think, you know, why not? That's very interesting to think about. Again, similar independent predictors, younger age, but now we have, in addition to spinal cord lesion, infratentorial lesion and positive oligoclonal bands. And also is sort of starting to have an attempt to stratify risk depending on the number of factors. So the more factors you have, the more likely you are to convert. If you have 4 of those factors, an 87% conversion by 10 years. Next. The most recent one that we have just published actually was looking at this prospectively. So this was a multi-center prospective study with a 2-year follow-up. And they found, again, similar risk factors for clinical event, age, less than 37, so young age, spinal cord lesions, and this time also gadolinium enhancing lesions. They didn't find oligoclonal bands, but they felt that this was probably a marker of the way that the study was designed. So overall, sort of in keeping with how we've seen the probability, the proportion go up from 5 to 10 years, at 2 years, it's 19%. But again, with stratification in terms of how many risk factors somebody has at the start of the study, you can see that if you have a higher number of risk factors, and if you have all three, particularly, you're at a very high risk at the end of 2 years of having developed a clinical event. So how should this lady be managed? Well, I think obviously we need to have a discussion of diagnosis of RIS, which is a very weird thing to have. You have something that looks like MS, that we see in people with MS on the scan, but you don't have it. I think something to remember, and I like this, came out in the Magnim's paper of 2018 that I've shown you, is this idea of the opportunity of not knowing. So yes, we could do some more tests that might give us, with the more recent papers, some idea of how we, whether we can predict how likely it is to convert to CIS or MS, but also having the opportunity of not knowing, because at the moment we can't modify that, although studies are being done on DMT. I think if we did, do more tests to think of prediction, obviously thinking about infratentorial lesions, because we look at the MRI again, MRI spinal cord, that's what I'd be particularly interested in, probably not with gadolinium in this case, because she's already had gadolinium enhancing lesions. Plus minus CSF, I'm not sure if I would do this invasive test. I'd be most interested in the spinal cord. And then I think that the person should be referred to the MS nursing team. We would, and we also have a number for MS coordinators that people can call if they're in relapse, and I would give that to this person so that she could call if she develops any clinical symptoms, and I would explain what I would, for her to look out for. I would definitely keep monitoring, definitely clinically yearly, because I think when you see someone and talk to them, you can tease out things they may not have thought was relevant. MRI is a bit moot. I think that if you have someone with a lot of risk factors that they might convert, then I probably would keep monitoring with MRI in a way, because they're likely to convert, and then you have a recent baseline scan. I think I would recommend vitamin D because of the evidence that has been shown in the past that low levels of vitamin D increases the likelihood of somebody developing multiple sclerosis. DMT, basically going to say DMT no, and that is there is no evidence yet for us to start disease modifying treatment. And I think that when we do, which it probably will come, when we do, I think we're going to stratify according to the risks. So we will probably start it in people, probably in the end, who might have subclinical features of MS. They're describing cognitive decline and things like that. We'd be wanting to start something. All those that have a high chance of converting to clinic, to the clinical syndromes. So there are clinical trials, 2 of them, teriflunomide and dimethyl fumarate. We would hope that we'd get some results from this in the next, year or so. And then quite an interesting one at the bottom, an academic trial, which we won't get results for a while. So that's me finished. It's a bit of a canter through this, and now I'll move on to Audrey. Thank you.
Those are my declarations. So incidental white matter lesions are the bane of my life. I'm often asked to look at white matter lesions that were found on patients' image for other reasons, such as in this case. And you'll be very familiar, this term non-specific white matter hyperintensities is used in great abundance by neuroradiologists, certainly by me. So what constitutes RIS, when you're looking at all these patients who with increasing age have more and more white matter lesions, you'll see here that in the first couple of decades of life, you tend not to see white matter lesions. And it's said that you're allowed 1 per decade. So you'd see here this white box, this is the incidence of white matter lesions, and it's by far the most common incidental finding on a brain MRI. So what constitutes RIS? As Camilla's already talked you through the criteria for RIS, this was the original Okuda criteria, which used the Barkov criteria. When the McDonald criteria was modified and I think simplified, you just need 1 or more T2 lesions in 2 or more of these areas, in periventricular, cortical, infratentorial, and spinal cord. So the most recent modified occluder criteria have incorporated the McDonald diagnostic criteria for dissemination in space into the RIS criteria. So the important thing, as Camilla has already said, is that we've got to exclude these white matter lesions caused by other diseases. And they've also, interestingly, from the radiology point of view, there is a note to caution radiologists about older patients because of this increasing likelihood of getting white matter lesions. You have to be a little bit more careful and perhaps seek out a higher number of periventricular lesions, because that's where white matter lesions commonly occur with age. Consider them sort of brain wrinkles. So the locations that I use, that most people use, that are very specific for MS, are juxtacortical and cortical lesions. There are not very many other conditions, possibly PML, progressive multifocal leukoencephalopathy, that starts in the juxtacortical white matter, but otherwise there are not very many other processes which give you juxtacortical and cortical lesions. The corpus callosum, particularly involving the inferior callososeptal surface of the corpus callosum, is very typical for MS, as are the peritrigonal white matter lesions and lesions around the temporal horns. Let me show you some of these. So here are a couple of juxtacortical lesions. You'll see that juxtacortical lesions are not just near the cortex, they immediately abut the cortex, or involve the cortex as well, such as in this case, I think that the cortex is involved. And you don't see any intervening normal white matter, which will look dark between the lesion and the cortex. These are very typical MS type lesions with Dawson's, you'll see these referred to as Dawson's fingers. They tend to be ovoid, larger, and they are orientated perpendicular to the corpus callosum. Here's a lesion in the temporal, adjacent to the temporal horn. And here are some lesions in the infratentorial brain on the surface of the pons and in the cerebellum. So if I saw something like this, I would not be reporting non-specific white matter lesions, and that my report would say that this is highly suggestive of demyelination. So I've already alluded to inflammatory lesions being often larger, and a very specific sign is that these lesions tend to be orientated around a central vein. So normally you look for the central vein sign on susceptibility weighted imaging. This is just a normal T2, but you can see it really nicely that there is a central vein there with a bright lesion around it. And here's a slightly more fluffy lesion where you can just get a hint. So you don't necessarily have to have very high strength magnetic imaging. So this was done on a 1.5 Tesla MRI scanner, and you can see the central vein sign. The paramagnetic rim sign, however, you don't see. This is something that it represents a chronic inflammatory lesion where there's ongoing inflammation, pocket of inflammation within a lesion that can go on for years. But this has been described initially with 7 Tesla MRI, but more recently there's been a paper that's shown that you can see these lesions on 3 Tesla MRI scanners. This is not something we look for routinely because we don't tend to do, not every hospital has a 3 Tesla MRI scanner, and you have to do a specific sequence to look for this paramagnetic rim sign, but this may be something that becomes more common as we get more 3T MRIs and start doing specific sequences. So here's a paper that describes the paramagnetic rim sign, and just to show you what it looks like a dark rim around the edge of the lesion where you're getting susceptibility artifact from probably hemosiderin deposition at the margins of the lesion. And here's another thing showing you another image showing you the central vein sign. So An important part of the diagnosis of RIS, of radiologically isolated syndrome, is making sure you exclude other diagnoses, most commonly small vessel disease, which can be either age-related or due to vascular pathology, which can be numerous. Other diagnoses include, particularly in younger patients, you often see subcortical white matter dots in migraine, in monophasic demyelination, you're more likely to be symptomatic. So that's the diagnosis of radiologically isolated syndrome is less likely to be a problem with ADEM. But there are other inflammatory conditions that can also give you white matter lesions. Let me show you some of these. With small vessel disease, the lesions tend to be smaller, much more symmetrical. They involve the deep white matter and the basal ganglia typically. You might see some holes or lacunes where there may have been a small previous infarct, and you might see some microhemorrhages, all of which would be very suggestive of vascular pathology. This was a patient that came through the MSMDT. Again, it was a patient who had an incidental finding of, actually it wasn't completely incidental because she'd had a visual field defect, but these white matter lesions that were described as possibly inflammatory. And you'll see that this very typical appearance of lots and lots of lesions going straight through the corpus callosum. This is very typical in Susak syndrome, which tends to differ from MS in that it involves the central corpus callosum. You see these lesions going right the way across, as opposed to just nibbling at the inferior margin. So the diagnosis was easy in this patient because she had multiple retinal branch artery occlusions. I forgot the retinal there. Sorry about that. This patient also inflammatory lesions in the brainstem, which enhance, these lesions all enhance. So these were all lesions of one age, and she also had an absent posterior pituitary bright spot, and this was Langerhans cell histiocytosis with brain involvement. This patient, which had a whole bunch of white matter lesions, pretty confluent in the brainstem. This turned out to be Behçet's. I can't say Behçet's. Sorry. So this patient again has the periventricular white matter lesions, and in the brainstem, in the deep white matter, but also has very typical signal abnormality in the dentate nuclei, which doesn't happen in MS. So this helps distinguish this condition from MS. And you'll see that they've also got a very atrophic medulla. That was adult onset Alexander disease. This came through again for review of white matter lesions. It looks nothing like MS because it's so florid. I mean, you can get some patients with chronic MS who do eventually get confluent white matter signal abnormality. But in this case, it's very typical for CADASIL to see this white matter signal in the temporal poles. So that was that diagnosis. Here are two, just going to end with talking you through two of our radiologically isolated syndrome patients who are currently going through the service. So the first is this 59-year-old lady who presented with an episode of diplopia in 2009. She's got a history of hypertension and diabetes and epilepsy, which was increasing. She was getting increased seizure frequency. So she had an MRI and shows that her corpus callosum was clear, no lesions in the corpus callosum. Sorry, I can't get this started if I don't change my pointer. And you'll see that she's got subcortical lesions, periventricular lesions, as well as a lesion in the dorsum of her pons, so in the left superior cerebellar peduncle. The rest of her infratentorial brain was clear of lesions. She was oligoclonal band negative. So we then, after reviewing that brain MRI, did her spinal cord. And I apologize that the imaging is slightly suboptimal. So you can see the cervical cord in this image and the thoracic cord here, and some axial images, which I will take you through at great speed was normal. There were no convincing cord lesions. So let's summarize this lady's findings. So she's got periventricular subcortical white matter lesions. She does have an infratentorial lesion, but she's also got some microhemorrhages. So none of this is particularly typical. The infratentorial lesion is a little bit more worrying, and she has accumulated a couple of new white matter lesions since 2010, but she's got a normal appearing cord. So we think probably she's still being followed up. She hasn't developed a clinical episode. We think the risk of conversion to relapsing and remitting MS is likely to be relatively low, as opposed to this patient who presented for an MRI for epilepsy. Again, he's got juxtacortical lesions, multiple juxtacortical lesions. Sorry, that was so quick. So juxtacortical lesions, periventricular lesions, lesion in the brainstem. And here, this is what, for me, really clinched it. The cord lesions, you'll see that he's got several lesions in his lateral cord. He didn't have any contrast, so we couldn't comment on whether or not he had any contrast enhancing cord lesions. That one may well have enhanced. But here you'll see the difference between the patients with the normal corpus callosum and the patient with the Susac syndrome. You'll see this little nibbling. This is very, very typical. Here's an MS lesion with an inflammatory type lesion in the corpus callosum, but it mainly involves the inferior surface as opposed to those Susac syndrome lesions which go right the way through and involve the central callosum. So this patient has multiple juxtacortical lesions, involvement of the corpus callosum, infratentorial brain, and several cord lesions. He continued to be followed up and had MRIs where he accumulated brain lesions, and at 7 years developed a cord syndrome and was diagnosed with relapsing or remitting MS and started on DMT. So just to finish up, as Camilla already pointed out, but I'd like to reiterate, the infratentorial and spinal cord lesions are really important. So it's very important to scan the cords of patients that you think have inflammatory looking type white matter lesions. And patients who develop gadolinium enhanced lesions on follow-up are known to convert more frequently to relapsing and remitting MS. So the key areas in radiology are distinguishing MS type lesions from other lesions and trying to assess the risk of conversion. And as Camilla said, there's the jury's out about how much MRI follow-up we do in patients with radiologically isolated syndrome. Magnins has recommended 6 to 12 monthly follow-up, which they've said is both can either be clinical or radiological, particularly in the higher risk patients. That's all from me. I'll hand over to Amy now.
Thank you very much, Camilla and Audrey. My name's Amy Harbour. I'm a MS nurse specialist and lead for South East Hampshire. So my borders, we've got approximately just under 1,000 people, and yeah, it's all community based. I did just start coughing a minute ago, so hopefully that's passed now, and this won't be interrupted. Okay, so what I'm going to be discussing is the impact that the RIS diagnosis have on those who are diagnosed and the MS nurse specialists. So these are my declarations. Okay, so just a bit of an overall what I'm going to be talking about. So what support is there out there for those diagnosed with RIS? The impact of those of RIS diagnosis for both the person with RIS and the MS nurses. Questions that are often presented to MS nurses, and are we prepared or equipped to deal with these? How to empower a person with RIS, a case study, and then a summary. Okay, so what support is there out there? So if you were newly diagnosed and you went onto Google, the top two things that come up are the MS Society and the MS Trust, and there's very limited information on there, as Audrey and Camilla have described the phenomenon, which was brought to attention in 2009, so I won't go back through to that. So other support, they people would get a lot of support through their neurologist. This is often statistics, epidemiology, prevalence, and monitoring guidelines. And, a lot of it is quite overlinked with migraines. And so the advice and the prescribing of them, but not DMTs. People can go to their GPs for advice, although this is often quite limited due to the fact that it is relatively new and there's not as much research done into this in the, that the general public know much about, as it is rare. They're often referred through to their MS specialist nursing team. And are we the right appropriate referral? And I think this can be discussed either way, and we will come back to that a little bit later on. So yeah, I just got a few quotes here for people who had been really recently diagnosed, and I just thought I'd read them out because I found them quite powerful, and there's a range of emotions. So I am living with the unknown. I'm not sure whether to be thankful and enjoy my life or be in fear of the possibilities of what next. Do I start a family? I wouldn't want children if I had MS, but I might be the 15 to 40% that doesn't develop it. I'm not going to go to any further scans. What's the point? I'll soon find out if I have it either way. Dealing with my diagnosis would be easier if there were some support services for me and my family. I want to be treated with immunosuppressants, but I'm not eligible. This makes me so angry. My body, my choice, and I need to live with the aftermath. And I think a lot of the MS nurses who are listening today will feel that when in clinic as well. And so I think it's really important to go through these range of emotions that people have. It is uncertain, it is the unknown. No one likes living in limbo land, and it's what is the right support to give at that point. Yes, so what impact does this have on the MS service and nurses? Do we have enough knowledge and expertise in this? I think that's quite a hard one. Over the last 5 years, there's been a lot of new nurses come into post, and I think it is very DMT heavy. There's limited not limited AMP, but it's steering past the AMP, and it is just focusing on blood monitoring, DMT side effects, and is RIS really covered? I think there could be maybe more information and some more sessions into this. And there is no clear guidance. How do we monitor people with RIS? And I think it's down to different organisations, different trusts, different leads of that service. So, for example, for in our service, we do it once a year. However, I know some people kind of leave it down to, empower the person at the beginning and leave it for them to make contact. Or is it appropriate? There's no real guidelines, so it's hard to really establish that one. So what advice do we give around family planning? Again, this is really tricky depending on their risk of developing MS. And going back to that quote earlier on, there's like a level of frustration because they don't know what to expect. And I know life is uncertain anyway. So it is just about managing their expectations, talking about family planning and going through the pros and cons with all of them, as we would with those who are diagnosed with MS. And how does this affect our workload or caseload? Well, we're pretty much all overstretched as it is. Adding a new dimension into the nursing world of MS, it does affect it. And especially if we are monitoring those patients yearly, for how long do we monitor them for? Is there a cut-off line that we say, okay, well, we've been doing this for 10 years, nothing else has developed, shall we hold it there? But that, again, going back, there is no clear guidance. So it does affect the workload, whether they have it goes on to develop MS, brilliant. But if it doesn't, why are they on our caseload? And are we paid appropriately for this? And is this in our job spec? I think that will differ from area to area, but it is quite interesting. It's also another thing to put in your job spec and your business design for the CCGs. Oh yeah, so this is just a few questions that I'm often asked in clinic, and I just didn't know how nurses out there felt confident in answering these questions. So, do I need to inform DVLA of my diagnosis? Do I need to inform my driver and insurance? Can I claim critical illness? Can I claim PIP? And shall I tell my employer? I mean, I'm sure many of you do know this, but next slide, please. So here are the answers. So yes, you do need to tell the DVLA. Yes, you do need to tell your driving insurance. You can't claim critical illness on RIS alone. You can't claim PIP on RIS alone. Shall you tell your employer? Up to you. Yeah, personal choice. Same with MS. You don't need to necessarily tell anyone anything. It's your condition. It's up to you. Yeah. How do we support people with RIS? Now, again, going back to a service that we provide, do we include them in our newly diagnosed days that we set out for people who are newly diagnosed with MS? Because in these days, we talk about relapses, what to look out for, when to contact the service, when to be concerned or do a urine test. Is it appropriate for them to come to these days? And I think there's pros and cons for all of that. Or do we need a separate support group? But again, on the flip side of that, is it appropriate, cost effective? How many people are really diagnosed with RIS compared to the general workload? Or should we be looking at to do this more of a national basis? Could there be a centre hub that people, however many times a year, come together, they have that diagnosis and get taught the facts and figures there and have a bit more of a support group there? I don't think it's necessarily right to be put in or showing people Facebook pages for people who have MS or shift MS. RIS is very different. And again, it brings to the next question really. So do we include them in our recently diagnosed packs? We don't currently at the moment, or should we have a separate pack? And what I was thinking when I was doing this presentation is I'm sure there's like nurse centres out there who have something like that. And I think the purpose of these meetings and webinars is to share best practice. So if there is anyone out there who has a specific pathway for either those who are recently diagnosed or their monitoring period to how long, I think it'd be really good to share and support this and work streamlined really. Yeah, so going back to the case study, to summarise, let me stop actually. So yes, so MS team do support people who have RIS, and early education leads to empowerment. So I do think it is vital that we do look at them when they are newly diagnosed and to tweak our plans and to invest a lot of time and energy into them so they understand their condition, so they know when to act on it. Regular appointments, is this good? Is it not? Is there a cut-off like I mentioned earlier on? But I do think that regular appointments, especially at the beginning, to address fears, anxieties, going back to those quotes, there's a whole range of things to deal from. It could be potentially a life-changing condition. And also to offer the recently diagnosed and to possibly signpost to counselling if possible. We know there's specific MS counselling groups out there, but not necessarily for those with RIS, and maybe that could be something that could be looked onto. And I think that's the end of my presentation. So back to you, Camilla.
Thank you very much to Audrey and Amy. I hope you can all hear me now. Still, excellent. Excellent talks, and Amy, you've raised some really tricky questions. I don't think it's easy to suddenly, come up with answers. So thank you for that. Really raised some food for thought. Anyway, let's see. We have 3 minutes for questions to answer very quickly if there's anything very burning. Otherwise, very happy to add some questions. I think that we've been told that that's an option. Add some questions, answer them after this. Perhaps tell us.
Whilst we're waiting for that, Camilla, can I ask how often you would, how many years you would follow up somebody who had a diagnosis?
Gosh, I haven't actually thought of that one. I think somewhere between 5 and 10. Mm-hmm. I think past 5, I'd be starting to feel a bit reassured, and then up. I mean, beyond, I would, as we're nearing 10, and we'd be both getting a bit bored. So I think it'll also depend on what risks they have of conversion. That's the point. But I think not beyond 10 as things stand. And nearing 10, between 5 and 10, it might go more to even less frequent, because I see them at the moment. I see somebody once a year, and I do that. And I don't think a nurse needs to do it as well, but a clinician, could be the consultant, could be the nurse, and it doesn't need to be duplicated. I think just to make sure that they are not, there's not things that they've not themselves come forward about. I do believe in empowering people with education, absolutely, but I think that you do I always, I do still personally anecdotally find things that people will tell me about that they didn't want to trouble us with. And also another reason they may not want to call is if they're worried, they don't want to really admit to themselves they've got something, and then they've got to call in because they know what that's going to mean, which is why I think face to face is good to really talk to them about it, or on the, or some appointment anyway. And I found that that's much more important at the moment for me than doing MRI, because we know they've got a risk. So it's, are they actually converting to having clinical syndrome? Okay.
Camilla?
One question, I'm sorry, in chat. Audrey, are you seeing something?
No, I was going to ask you a question to follow on from
No one's asked any questions. One question, Audrey, and I'm going to have to run. Sorry.
Just a quick one. With the imaging, if they were accumulating lesions but not getting clinical symptoms, would that influence your decision about follow-up?
About follow-up? That's the thing about what you've been doing the MRI. I mean, yes, it would. So a younger person with developing ongoing lesions, if I was checking with MRI, then I would continue to follow them. So it's such a strange one. I mean, what they haven't said in all the predictors is, the predictive trials that I've come across is, are people continuing, have they followed them up, and are they continuing to accumulate? Because you do feel that really, it's only a matter of time then before a lesion hits something that's clinically relevant. It's such an odd concept. And what I couldn't get from the papers is, what is the difference between those in the end, that 50% of people that have a clinical episode, really? I mean, there's the predictors and those that don't, how were they accumulating lesions at all? I mean, that's the sort of thing, I don't know that question. We're still a bit in the dark, but it was good to go through all this again and see that there is a possibility to stratify the risk, to have a think about it. So if someone has spinal cord lesions, they're young, they've got gadolinium enhancing lesions, you're worried. But if they don't, then, I mean, particularly the spinal cord, then you are less worried. I'm so sorry, everyone. I'm going to have to go. Okay, I've got to race to go and see people now. So thank you very much for your attention. Bye-bye.
Thank you very much.